and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request Professor Dr. Arvind Krishnamurthy to start this session. Welcome, sir. Over to you.
Thank you, Navdeep Singh ji. Thank you, DNB, Som, and of course, sir, for the opportunity. The mandate given to me is to speak on carcinoma of the buccal mucosa. It's a vast topic by itself, although it's very subsite specific. Being an oral cancer awareness month, it's apt that we discuss about oral cancers. And I would try to give a broad overview of this particular topic. If we actually see the So the background being that there are 7 sites in the subsites of the oral cancers. Buccal and tongue are most common, constitutes nearly 50% of the cancers. In fact, if you see the ICMR mandate, they actually put it as mouth cancers rather than buccal cancers. So if you are reading some data on buccal cancers, be aware that mouth cancers will be synonymous with buccal cancers. More common in the Indian subcontinent, but I must tell you that within the subsites of the oral cavity, there is a clinical as well as a molecular heterogeneity in these cancers. Broadly, when we discuss about head and neck cancers, about 4% of new cases in both sexes globally, as well as 4% of deaths. But in the Indian subcontinent, close to 60% of the head and neck cancers is the contribution to the global numbers. The Globocon 2020 data says you have up to 377,000 new cases and 177 new deaths in 2020, and this is some global data. Within the subsites, what we find is oral tongue cancers, the incidence seems to be slightly increasing. Buccal cancers, not that much. This was seen by our group as well. When we consider the geographical variation in incidence, and what is highlighted in the dark blue are the places in which the incidence of oral cancers and buccal mucosal cancers are slightly higher. Definitely very high in Southeast Asia and India, but very rarer rather in the Europe and in the US, where it constitutes close to 3 to 4% of all cancers. But what's more important is the disparities in the head and neck cancer care and management. The LMIC, the low middle income countries, account for 67% of all the head and neck cancers and a whopping 82% of the head cancer deaths. Further, it's projected that head and neck cancers are anticipated to rise by around 30% by 2050, 1 million cancers by 2030. Definitely, it's a big public health problem. And one of the reasons said is that there is a delay in the index presentation of these cases, so much so that we all see that close to 85% of all our oral cavity cancers present in locally advanced stages, and this is our data as well. But a very interesting feature was that when we analyzed the oral cancer patterns of care with regards to presentation, what we found that buccal cancers actually fitted the paradigm of having presenting in the locally advanced stages, whereas tongue cancers seem to present in a much more earlier stage as compared to the buccal cancers. And more so, tongue cancers was not associated with habits of tobacco and alcohol, whereas buccal cancers had the traditional habits of tobacco and alcohol. So this is something that we all know, but what do we actually do about this in terms of intervening to have an early diagnosis of these cancers? And we have come about with a strategy called the push and pull strategy, which we published later last year in the Cancer Epidemiology, wherein we have suggested targeted interventions across socioeconomic and determinants, also targeting symptom awareness and sensitizing the people, especially the women, with regards to early diagnosis of oral cancers. With regards to age and gender trends, what we find is that oral and especially buccal cancers have a male preponderance. Earlier in the last century, it was significant. The preponderance was 4:1. More data shows that the gender gap seems to be narrowing. The preponderance seems to be 2:1. The male preponderance continues. When we come to the age of diagnosis, and this is the global data which says that the non-virally associated head and neck cancers are in the later part of the sixth decade, but we know that Indian cancers tend to present a decade earlier, so maybe in the fourth or third decade, and we are seeing more younger and younger patients with oral cancers as well, even in the early 20s and 30s as well. But when it comes to the virally associated head and neck cancers, the HPV associated oropharyngeal cancers, again, it is a decade earlier, 53 years for the HPV positive oropharyngeal cancers and 50 years for the EBV positive or the nasopharyngeal cancers. When we come to the applied anatomy of the buccal mucosa, and this is something that we all know, but it is worth remembering that unlike the tongue, the buccal mucosa is lined by non-keratinizing stratified squamous epithelium. It is the mucosal lining of the cheek, extends from the oral commissure to the RNT anterior to posterior, and from the mandibular and maxillary gingivobuccal sulci inferiorly and superiorly. One must understand that the thickness of the cheek is 1 to 3 centimeters, and it is very important when we give the third dimension margin, and especially you must understand the fact that the mucosa of the buccal mucosa is actually firmly adherent to the buccinator muscle. So one must keep this mind keep it in mind while trying to give a wider excision for these patients. Also keep in mind the anatomy of the parotid duct, which pierces the oral cavity adjacent to the second maxillary molar. And it is important not to keep the duct. You are various ways of managing the duct is there, and one must keep cognizance of the duct, either ligated or recanalize the duct. One must also remember that there are a lot of minor salivary glands which are present in the buccal mucosa, and this may cause other salivary tumors also in the buccal mucosa. Majority of them are, more than 95% in fact, are squamous cell carcinomas. But again, because of the presence of minor salivary gland and lymphoid tissues and other connective tissues, you may rarely get salivary gland tumors, lymphomas, sarcomas, melanomas, and other tumors as well in the buccal mucosa. The other thing is the sensory innervation, the lymphatic drainage. Majority of the buccal mucosal cancers drain into the submandibular glands and the level 2 region. When it comes to the risk factors for the buccal mucosal cancers, this was something that we were traditionally knowing, the 5 S's. Of course, more relevant is the smokeless tobacco. Spirits is important. Syphilis and spices is something that we don't see much. Of course, there's a lot of exciting buzz on and evidence to say that sharp tooth and poor oral hygiene is a causative factor for oral cancers and buccal cancers as well. Human papillomavirus seems to be a newer kid in the block, although not new. It's been there for about a couple of decades. As was said, that smokeless tobacco is very, very important in our context. And it causes submucous fibrosis, making it difficult to access, diagnose, and manage some of these patients. Our group has done some exciting work on biomarkers in oral submucous fibrosis. We have found secretory proteins, and we believe that it can differentiate between the disease prognosis and important in risk stratification of the oral submucous fibrosis. Our group has further done some work on oral stem cell markers, and we believe that this will have an important role to play in the prognosis of the submucous fibrosis. When it comes to the role of HPV in oral cancers, about 10 years back, we believed that there could possibly a role of human papillomavirus in the oral cancers. But subsequently, when we did a consensus statement about 5 years back, we felt, or the larger understanding was, the role of HPV in oral cancers is unclear. Routine HPV testing is actually not recommended. And now there is more and more evidence to say that the prognostic significance is predominantly involving the oropharyngeal subsite, wherein we have a separate TNM for oropharynx as compared to non-oropharyngeal cancers. And we believe that HPV is exclusively associated and prognostically associated with the oropharyngeal subsites rather than the oral cancer subsite. And this we found by exome sequencing data, which we published early last year, wherein we felt that HPV is absent in oral cancers. We also came up with the fact that P16, which is a surrogate marker of HPV in oropharyngeal cancers, does not have a clinical relevance in oral cancers as well. And there could possibly something called as a HPV independent P16 expression, which confers a slightly poorer prognosis for these patients. So coming to the broad principles of the management, and this is the meat of the talk, as training buddies, you must understand that history taking is very important, especially with regards to the habits of tobacco, alcohol, and other habits. Clinical examination with regards to the T size important. It will help to sort of plan a proper biopsy for these patients. More importantly, it is important to look for field cancers elsewhere in the oral cavity and potentially malignant conditions as well in the oral cavity and the entire aerodigestive tract. It is important for us to know the malignant transformation rate for individual oral potentially malignant conditions, which will come to the subsequent slides. Important to look into the regional lymph nodes, the cervical lymph nodes, all groups, and majority of the oral cancers, including buccal cancers, spread to the lung as a part of distal metastasis, close to about 5 to 10%. So sometimes in the locally advanced, we tend to do a chest imaging for some of these patients. It's also very important if you have a proper referral system of sending some of your tobacco users to a tobacco cessation clinic, dental rehab, speech and swallowing, distress, nutritional evaluations, and all these things are an important component of the multidisciplinary management of oral and buccal mucosal cancers. Now, obviously, since majority of the oral cancers will go in for surgery, medical fitness for these patients is important. This is a paper of 2020, which I will urge you all to read, about the malignant transformation rates of various oral potentially malignant disorders. On an average, 7.9% is the malignant transformation rate. It sorts of varies from lichen planus to oral submucous fibrosis, wherein in oral submucous fibrosis, the malignant transformation rates is around 5%, lichen planus around 1%, and PVL, it is close to 50%. So when it comes to imaging, we all believed that ultrasound of the neck is very, very important, but I believe that the investigation is slightly hyped. Of course, it is very good when there is a clinically positive node in the neck, wherein you can do a targeted FNA of these lesions whenever possible. But by and large, for a negative neck, ultrasound sensitivity and specificity is very, very less. And this is something that we have observed in our series as well. When it comes to local imaging, again, cross-sectional imaging seems to be superior for buccal mucosal cancers. And this is the commonly called as the puffed cheek technique, wherein you are able to sort of, make out exactly the entire contour of the buccal mucosa, the thickness of the buccal mucosa, the relationship with the mandible, and we are able to see exactly the entire dimensions. So a puffed cheek SAG view is something that you'll be able to sort of appreciate the dimensions, is something that we normally use in regular practice. MRI, rarely for buccal mucosal cancers, but you may tend to use it in some ambient cases. There is a lot of buzz of PET-CT scans to evaluate the cervical lymph nodes, and this is some data which is in evolution, but in regular practice, we don't normally use PET-CT scans to evaluate for the cervical lymph nodes. You all are aware of the TNM staging, and I thought it is mandatory. It needs to be emphasized. Of course, the new TNM staging has been in vogue for about 5 years now, but it's important to understand the concepts of tumor thickness, depth of invasion, which is now superseding EMI as an important prognostic factor, and also the presence of extranodal extension, which is now a category of N2A or N3B. Further revisions in the oral TNM has happened over the years. Also, we are now realizing that even extranodal extension is categorized as no extranodal, minor or major extranodal implications. And I believe that some of these changes will happen periodically in the subset of oral cancers as well as buccal cancers. The broad philosophy of head neck cancers, and this is relevant to oral and more specifically to buccal cancers, which we are talking today, is encapsulated in this slide. Early stage cancers, that is stages 1 and 2, we do a single modality and we prefer surgery, and I will give you the evidence for that. You may also use radiotherapy, and I will also give you some of the evidences against the use of radiation therapy. In the locally advanced cohort, that is stages 3 and 4, it's a combined modality, preferably surgery followed by post-operative radiation therapy. And you may also selectively use non-upfront surgical modalities, which I'll briefly allude to in the subsequent slides. Very few randomized controlled trials comparing surgery with radiation or CTRT. This is the 5-year or the 10-year update of the only randomized controlled trial that was attempted in the subset of oral cancers. Of course, it was not specific to buccal mucosal cancers. Clearly showed that the 5-year DFS in oral cancer patients treated with surgery was way, way superior, 68% versus 12%, which was treated with non-surgical modality, that is chemotherapy and radiation therapy. This was further supported by the NCTV database of more than 20,000 patients, which clearly showed that patients who were treated with primary radiation therapy, there was an associated increased risk of mortality for these patients. And so much so that the US believed that primary radiation therapy was actually was more used in the elderly patients and Black patients, suggesting that a wider disparity in cases of cancer care there. More recently also, you had the ARTSCAN-2 study, although not statistically significant between preoperative and postoperative radiation therapy, clearly showed that toxicity was more pronounced in the preoperative radiation therapy group. So by and large, for most of the early stages and resectable advanced stages oral cavity cancers, upfront surgery would be preferable without any, if it is done without any major long-term and functional deformity for these patients. And generally, definitive radiation therapy is reserved for patients who are unfit or who refuse surgery. Sometimes labial mucosal cancers, people say that brachytherapy is good for these patients, but carefully performed surgical exercise will actually yield reasonably good cosmetic outcomes for some of these patients. So as I had reiterated, upfront surgery is the mandate for all resectable oral cavity cancers. Now, when we come specifically into the approaches, you can have two broad approaches for buccal mucosal cancers, the per-oral approach and the cheek flap. That is, you can use the upper and the lower cheek flaps. You can use the per-oral approach in some of these patients where the lesion is well localized, mouth opening is adequate, and you're able to actually go all around the tumor. In cases where the mouth opening is not adequate, when the patient has trismus or when the lesion is slightly larger, then you may want to use one of the cheek flap approaches, lower cheek flap for the tumors that are there in the lower, close to the mandible, and upper cheek flap in case of tumors that may be close to the upper gingivobuccal sulcus. There is also important to know the involvement of the mandible. And in case of gross tumor invasion, generally in edentulous opposed radiation therapy, or when there's a gross paramandibular spread, as in this case, even though the mandible is not totally involved, you may land up in doing what is called a segmental mandibulectomy, wherein the entire segment of the mandible is removed and reconstructed. It's also important to remember that a centimeter of bone should, whenever the centimeter of bone is not possible, then you would do a segmental mandibulectomy. And when it is possible, you may do what is called as a marginal mandibulectomy, wherein you do it when tumors is close to the mandible, abutting it, but not actually involving it. You try to get a 5 millimeter or a centimeter margin there. In terms of limited bone erosion, also you may tend to do a marginal mandibulectomy. Various types of marginal mandibulectomies, horizontal that we more often use in case of buccal mucosal cancers that is involving the lower GBS. Very rarely you tend to use the oblique cuts. In case you can use the sagittal cuts, especially in case of tumors that are involving the lingual side and are involving the mandible from that. But majority of the times for buccal mucosal cancers, what we practice is the horizontal type of marginal mandibulectomy. Of course, there is something called as a reverse marginal mandibulectomy that happens with the node involves the lower border of the mandible. When it comes to the concept of margins, and it is very important, and I can't reiterate enough that every attempt has to be made to ensure a negative margin. Multiple studies have shown that positive margins are associated with the worst prognosis. It's important to sort of know that more than 5 millimeters of clear histological margin is important. So you don't aim at 5 millimeters, you aim at a centimeter or more, so that you factor in the margin shrinkage ex vivo and after formalin fixation, so that you're able to achieve at least a 5 millimeter margin. Some studies show that lesser margins may sort of be adequate, but believe me, they're all retrospective analysis of some data. It's very important, at least in our cohort, to sort of tend to achieve a more than 5 millimeter histologically negative margins. Use a frozen section whenever it's available. You may want to use it, and I know in many centers where it's available, they routinely use a frozen section for specimens for revision of margin based on frozen section. But I must tell you that the published literature has failed to show any conclusive benefit of the use of frozen section in actually improving the oncological outcomes. So if you're working in a limited resource setting wherein a frozen section facility is not available, there is some data to suggest that if you're able to achieve a gross 7 millimeter margin, then you may be good in at least 96% of the cases. There's an ongoing randomized controlled trial from the Tatas that is examining gross examination versus frozen section examination. And this study will possibly give us more insights into the use of frozen section or against the use. There is also a concept of borderline resectable oral cancers. It's a very controversial topic, but I'll try to give very, very brief some insights into it. There is a definition given by the Tatas: disease, which is actually reaching up to the zygoma, or swearing, which is reaching up to the zygoma, extensive soft tissue involvement up to the hyoid or skin infiltration, and involvement of the infratemporal fossa. Sometimes you may get away with doing an upfront surgery in some of these patients. There's a controversy whether to do an upfront surgery or go the neoadjuvant way. I'm not going deep into the controversy because that itself is a talk in itself, but I must say that there is a number of publications to suggest that if you are not able to achieve an R0 resection, that's the most important point, then you can go the neoadjuvant way. And complete surgical excision, at least in the publications that were there, were seen in up to 40% of these patients. Even some of the unresectable or borderline resectable tumors came into the purview of surgery. And it is the patients who underwent surgery who had the best survival. Patients who did not undergo surgery did not do well. And here you have 2 or 3 other concepts of using a 2-drug versus a 3-drug regimen of NACT. TPF, that is the 3-drug regimen, is preferred. Most of the times it gives a better outcome for these patients. But in real world, we are not able to use a 3-drug regimen. We tend to use more often the 2-drug regimen. 3-drug may be useful, may be used in real world in only about 20 to 30% of the patients. And there is also exciting data again from the Tatas to say in some of these patients, you may use Paclitaxel carbo combined with oral metronomic chemotherapy. Believe me, these are subsides, or these are options only when it is unresectable or borderline resectable, and not when the tumors are upfront resectable. There is also an exciting concept of use of neoadjuvant chemotherapy for mandibular preservation. This was a concept, or this was seen in 20 years back in Lisa Licitra's paper, wherein 20% of the mandibles were preserved as a result of neoadjuvant chemotherapy, but that was not the primary outcome of their study. They used neoadjuvant chemotherapy and incidentally found 20% of the mandibles were preserved. But you have got some exciting buzz from Dr. Chowker's paper published last year in the JCO, that said that close to 47 to 48% of the mandibles could be preserved. Of course, this is phase 2 data. There's an ongoing phase 3 randomized controlled trial, and we would wait. But I must tell you again, in real world practice, to use NACT for mandibular preservation has severe logistic issues. But we have also attempted this approach, and we also have found that definitely mandibles can be preserved in a proper selected subgroup of patients. Moving on to the management of the neck. Of course, this is a landmark trial from Dr. De Cruz in the NAGM, close to 9 years since its publication now. But I must tell you that majority of the cases in this paper was tongue cancers and not buccal mucosal cancers. Buccal mucosal cancers constitute a very small proportion of the 500 patients that was analyzed in this paper. So with doing an elective neck dissection, you could prevent 1 recurrence for 4 neck dissections and 1 death for 8 neck dissections. And subsequently, there have been multiple meta-analyses, including the randomized controlled trial by the Hutchison's group, the SENSE study, which showed that elective neck dissection benefited all subgroups of oral cancers, including buccal mucosal cancers. And to do a proper elective neck dissection, you must remove at least 18 nodes, and this is a part of various other guidelines as well. So what's new in the front of neck dissection? Sentinel lymph node biopsy is, of course, it's a standard of care in many other cancers like penile cancers, melanomas, breast cancers, and possibly coming up in many other cancers as well. Some recent buzz in head and neck cancers. We've also got some exciting preliminary data on the use of sentinel lymph node biopsies in oral cavity cancers. But the more recent buzz came from two randomized controlled trials that were published in 2019 and 2020 from the Japanese group and the Sentimorel group. Of course, you have got an ongoing trial, and all the trials, at least both the trials, actually showed that sentinel node biopsy was non-inferior to elective neck dissection. So one must, if you deep down, if you dive and you do some analysis into the trials, you must know that although both these randomized controlled trials were very well, reasonably well conducted, I must say, they were non-inferiority trials, but somehow they tended to assume a slightly higher non-inferiority margin of 10 to 12%, which a lot of experts feel is slightly higher. Some of the trials, you had oropharyngeal cancers as well. We know that HPV positive oropharyngeal cancers has a slightly different biology and prognosis. Also, the fact that neck and shoulder morbidity, which is a very important outcome of sentinel node biopsies vis-a-vis elective neck dissection, and the cost effectiveness and logistics were not adequately addressed in some of these. In some of the trials that they showed that the shoulder and neck morbidity actually leveled off after 1 year. Also, there were some issues with the choices of adjuvant treatment. So for various reasons, it's not been routinely incorporated primarily because of logistical issues. Of course, you had some more recent data from Tejpal Gupta's group that of an IPD of the patients in the randomized controlled trials, and they concluded that sentinel node biopsy was non-inferior, although not equivalent to elective neck dissection. So you might find a lot of data to suggest sentinel lymph node biopsies as a possible option, although it's not regularly practiced, but I must say that it is a viable alternative. You may use it in some of your patients very selectively if you have all the logistics with you. Shifting gears to reconstruction, again, it's actually based on the defect. Sometimes in a small, non-thick T1 tumors, you may achieve a primary closure with doing some sort of local mucosal mobilization. Split skin grafts we used to do much earlier, but I must say that the uptake of skin grafts in the buccal mucosa is very tenuous. Sometimes they don't take up very well. Very rarely that you get a good mouth opening, and a failed skin graft will lead to a trismus and very poor aesthetics. So, but this is in one case in which the skin graft is taken very well, patient mucosalized, and this was something that was done more than a decade earlier. Buccal pad fat is something that is very exciting. So in small defects, some patients have, especially the obese patients, they tend to have a lot of buccal pad fat. So you can pull some of the buccal pad fat. It mucosalizes extremely well. So we tend to prefer the buccal pad fat over the skin graft for thinner lesions which are involving the buccal mucosa, and smaller lesions as well. For small thin lesions, prefer the buccal pad fat over the skin graft. For deeper lesions, of course, as I said, the aesthetics is not that great. You may use some of the local flaps or regional flaps. The nasolabial flap can be used. Infrahyoid flap, which we tend to use more often. Temporoparietal flap is also an exciting option. And also the submental flap, I think some groups have used it. We have also used it, but I must say that we use the submental flap. Of course, we described this technique about 10 years back. Follow-up is something that we published a couple of years back. We tend to use the submental flap for the vericopapillary lesions of the oral cavity and not for frank squamous cell carcinomas. If it's a squamous cell carcinoma, we somehow tend to avoid. But of course, there is some data in literature to suggest that even for buccal mucosal squamous cell carcinomas, if you carefully do, you may get oncologically equivalent results of submental flap, but somehow we tend to use it only for vericopapillary lesions of the buccal mucosa, wherein frank invasion is not there. Of course, when you remove the mandible, you have various other options. You could use the pectoralis major, you could use a free flap in some of these patients. And we have actually sort of, tried to address this issue by comparing the free flaps versus the loco-regional flaps in a paper which we published close to about 9 years prior. Again, when it comes to shifting gears to adjuvant therapy, and this is something that is very common, but I thought for the sense of completion, we must know about this. All node positive patients for sure. Some of the high risk node negative, and this is an area of controversy, it's work in progress. You may use adjuvant radiation therapies for some of these indications. Add chemotherapy when there is margin positive or extra nodal spread. Also, when multiple other high risk factors are there. Traditionally, dose is cisplatin at 100 milligrams per meter square every 3 weeks, but sometimes due to logistical problems or toxicity issues, patients may not be able to tolerate, but our experience has been different. We find a lot of carefully selected fit patients are able to actually tolerate the 100 milligrams per meter square dose. But you have got some exciting data from the AIMS group that was presented at the ASCO last year. We are awaiting formal publication of the paper of the cisplatin at a lower dose of 40 milligrams per meter square. So finally, touching about recurrent and metastatic oral cancers, and this is a very important issue because a lot of these patients present in locally advanced stages, some in the metastatic stages, and invariably about 40 to 60% of them recur. So very important to know how to manage some of these recurrent buccal mucosal cancers as well. It's a very challenging proposition. No definite staging system. We extrapolate the staging system from the initial treatment factors, and we don't really know how to exactly incorporate some of the high-risk factors for these patients. But I must tell you that salvage surgery provides the best opportunity for the long-term survival for these patients. But of course, with the advent of newer immunotherapy agents, this dogma is currently being challenged. Of course, it all depends on proper patient selection, and also to find whether the patient is fit enough to undergo the surgery. As I said, the surgeries are technically challenging. You may have mortalities up to 5%, major complications in up to 20 to 40% of these patients. Sometimes the morbidity of fistulae, necrosis, carotid rupture, cerebrovascular accidents, and tube feeding dependence and tracheostomy dependence are there. So one must carefully select some of these patients and do judiciously good sort of cover in terms of microvascular flaps for these patients. Now, again, the issue is salvage surgery worthwhile? And you have got a meta-analysis that was there published a couple of years back of 16 studies. If carefully selected, you have got a 5-year overall survival of close to 37% of these patients. If not amenable for salvage surgery, re-radiation is an option. There is some exciting data. Of course, there is an improvement in the disease-free survival, less data to suggest overall survival advantage for some of these patients, but one must know that again, radiation has severe late toxicities up to 40% of these patients, and treatment-related mortalities can also occur. So in practice, although this seems to be an attractive proposition, very rarely are radiation oncologists willing to re-radiate some of these patients. Of course, when the disease-free interval is longer, more than a couple of years, and the patient's skin and is pliable, they tend to use it. But more often than not, I think re-radiation is very, very selectively reserved for some of these patients. What if the patients are not amenable for salvage surgery and not fit for re-radiation as well? You've got a lot of buzz. Initially, we didn't have much data of systemic therapies in head and neck cancers, and that's a new subject in itself. The extreme trial by Vermorken in 2008 changed the paradigm. And very recently, the Keynote 148 study of immunotherapy by Barbara Burtness also changed the paradigm of some of these cancers. So you tend to triage these patients based on platinum sensitivity, the tumor volume, the symptom burden, PD-L1 status, how the performance status of these patients are there. And based on that, you tend to sort of divide your patients into platinum sensitive, platinum refractory, and you have various options to take up for these particular patients. But in the low middle income countries, what happens is you a lot of our patients don't actually get to receive the immunotherapy, and only about 2% of all our patients tend to receive immunotherapy. Exciting data again from the Tatas, which says that you can use metronomic chemotherapy. You've got now good phase 3 data to substantiate this. And in case of platinum refractory disease, which is again a big bugbear, you have, of course, immunotherapy, which gives a reasonably better performance PFS advantage in these patients. But there is a promise of a triple drug metronomic therapy, again, which shows that you have got a 6-month OS of about 60% of these patients. So initially, you never had options, but now you have options in the form of immunotherapy, an exciting buzz in oral metronomic therapy. Future perspectives, of course, our group has done a lot of work on some of these markers, but in cases of high-risk pathological features, as a group, as a head neck cooperative group, we came together and put up and pooled some of our data, about 740 odd patients. And what we found that a cumulative number of adverse histological factors, if they are more, then it predicted a poorer prognosis for some of these patients. And we also found the adverse impact of perineural invasion as a single independent prognostic factor in our cohort as well. If you come to the broad survival trends in head neck cancers, there has been only a modest improvement over the past 3 to 4 decades. But the 5-year survival rates have jumped up from 55 to 66%. And believe me, this is not buccal mucosal cohort only. This is the entire head and neck cancer cohort. And this is largely driven by the fact that the majority of the global data comes from the HPV positive oropharyngeal cancers. So when we take the cohort of oral cavity cancers and especially buccal cancers, you may not see that much of an improvement in the overall survival of these patients. And considering the fact that some of these cancers are projected to rise, it's very important to prognosticate and even more important to prevent some of these cancers, considering that we are not able to make remarkable improvements in the overall survival for some of these patients. And again, this is something that seems elementary, but is something that I would urge, being the Oral Cancer Awareness Month, important to promote oral health awareness among the patients and physicians. And we have got some really good Indian data on oral cancer screening. The model has been validated also in a publication last year, saying that in high-risk patients, you are able to save multiple lives for these patients. So the final take-home message for me is that in buccal mucosal cancers, I feel that in the subsites of oral cavity cancers, buccal mucosal cancers is unique. There are inherent clinical as well as molecular differences between buccal and tongue cancers. This is a work in progress, and our group is actually working on this as well. But broadly, from the clinical perspective, upfront surgery is preferred definitely in the early cancers and in the advanced cancers whenever they are resectable. Elective nodal dissection for all subsites or for N0. And of course, if it's positive, then you may do a comprehensive neck dissection. Sentinel node biopsy is a promising concept, although there are logistics for it to use in real time. But if you have all the logistics, you may use it in your practice. Reconstruction, of course, as I said, in real world, you may not be able to use free flaps for the majority of these patients. You're not doing any harm for some of these patients. Of course, you sort of tailor it to the defect. And adjuvant treatment, a lot of buzz is happening in the adjuvant treatment. And more buzz is also happening in the space of recurrent and metastatic oral cavity cancers, wherein you have many other agents. But for the youngsters, I must say that oral cavity cancers, especially the buccal and the gingivobuccal cancers, are our cancers. We see it as a more important problem. There's an enormous potential for research, both in the diagnostics and management of these patients. And I would urge all the youngsters who are listening to sort of focus more on these cancers, because they are an important public health problem right now, and they are projected to increase in the coming decades. With that, I would like to stop screen share, and I would like to thank the NBE, Dr. Somshekhar, Dr. Kausab, and Navneet Singh ji for the opportunity, and happy to take any questions.
Arvind, that was awesome, fantastic, beautifully covered, because buccal mucosa, so many things are there, but a very nice, balanced, evidence-based, clear-cut message you gave to the students, no controversy. As always, you really assimilate the knowledge, but the ability to put it right way for students is amazing. Looking at your slide deck, it shows the effort that might have gone to prepare it. It's not easy on a vast topic like this. My heartfelt thanks. Awesome, that is. Thank you very much. There are some questions in both Q&A and chat box. We'll start answering them, please. Yeah, please go ahead.
Okay. What are the various biomarkers, Dr. Vijay? I can see only one question now in the chat. Are you able to see any more?
Yeah, in Q&A, there are a lot of questions.
Okay, I'll just check it.
Yeah, open the Q&A. Yeah.
Okay. Yeah, how to define paramandibular disease? I think Dr. Avnish asked this question. This is very important. So there's this disease which is there on either sides of the mandible or one side of the mandible, but actually the mandible is not involved in some of these patients. So traditionally what we used to do is we used to do a segmental mandibulectomy for some of these patients. But as I said, there is this concept of mandibular preservation, and this is where I think the concept of mandibular preservation. So the disease is around the mandible, but not actually involving the mandible. So that's paramandibular disease. So what happens is, if you want to do a marginal mandibulectomy, as I said, you must have at least a centimeter of length of mandible. When there is extensive paramandibular disease, you actually land up pushing the tumor or the periostea, which is something which we don't normally advise. Periosteal stripping is something that we don't advise for paramandibular disease. Either you have to do a segmental mandibulectomy, or as I said, there is some buzz to suggest that you may use the neoadjuvant chemotherapy approach. But as I said, the data is only a phase 2 data. We are awaiting phase 3 data for some of these patients. Approach, midline split, angle split indications. Yeah, I think that's again, Dr. Sandeep asked a very important question. I think there are various ways in which you can split. As I said, like, it's important to know that some of these patients, if the tumors are small, accessible, mouth opening is good, then you don't do any of these things. And we tend to sort of avoid some of these. But sometimes when the lesions are slightly larger, when you want to do some sort of marginal mandibulectomies, it's important to split. There are two mechanisms of split. Either you split it bang in the midline, or you do a angle split for some of these patients. Must say that, previously the angle split was not considered or not recommended, just for the fact is that, you are sort of disrupting the commissure. So you're disrupting the orbicularis oris at the level of the commissure, and people believed that if you disrupt it at the commissure, then there may be issues with oral competence, and which cause a lot of drooling. But this is not something that we see in real world practice. We tend to use some of the angle split approaches, especially for lesions that are slightly posteriorly based, which are not reaching up to the commissure. So if you carefully reconstruct some of these lesions in 3 layers, then the angle split works well for these patients. But if the tumor is involving some sort of the commissure, then if you do what is called as a midline split, what happens is sometimes you lose the vascularity of the part of the lip that is there. So you must be very, very careful to preserve the angular artery that is there, or the facial artery branch, whenever you're doing a midline split. When you're doing an angle split, you don't have that much of a problem in some of these patients. So in the immunotherapy era, whether nivolumab or pembrolizumab will come in NACT and borderline resectable cancers, especially in high PD-L1 smokers. I think this is, it is possible. We are seeing that, the use of immunotherapy is come in a big way. At least in lung cancers, you have a good phase 3 data to suggest the use of immunotherapy. But in head and neck cancers, there is some data to suggest that you are able to achieve what is called as a maximal pathological response rates, close to around 40 to 45% of these patients. But again, the data is work in progress. Again, considering the fact that a majority of the head and neck cancer patients are smokers, you tend to have a lot of mutations. But I must tell you that head and neck cancers, the immunogenicity of these cancers seems to be slightly less. There was a question of biomarkers in head neck cancers in some of the other part of the chat, which I sort of observed. But the problem with head and neck cancers is you don't have that much targetable biomarkers for these patients. For example, EGFR is expressed in close to 100% of the oral cancers, but then you find the data of cetuximab is not that compelling. Compared to lung cancers and various other cancers like melanomas or kidney cancers, which seems to be very, very immunogenic, for some reasons in head neck cancers, although there are biomarkers, but somehow to target some of the biomarkers and get robust results from these biomarkers is something that is work in progress. And I believe in the immunotherapy era, definitely you have got some overall survival advantage in the recurrent and metastatic setting. And logically, I am sure that it will progress in the adjuvant and possibly in the neoadjuvant space as well. So why sentinel node biopsy is not standard of care in oral cancers? I think that's a very, very important question from Manish. I think I tried to briefly allude to the fact when you do a sentinel node biopsy, of course, in oral cancers, what happens is that, it's in a very, very close proximity to the tumor, especially the floor mouth cancers which are there. So you may have something called as a shine through effect for some of these cancers. So you must keep that in mind when you operate, because of the very, very proximity and very difficult to actually sort of, keep the probe in the head and neck and try to identify it. So these are some logistical issues while doing the sentinel node. The other aspect is that, you have the logistics of doing serial sectioning and also added immunohistochemistry for these patients. Again, if you see that, that adds to a lot of cost for some of these patients. The other fact is that, about 20 to 30% of the times you have micrometastasis. So at least in a third of the patients, you may have to sort of go back and address the neck. So these are some of the challenges of doing the sentinel node in head and neck cancers. But I think, and also the fact that, when it comes to, so when do we do a sentinel node? In cases of breast cancers, of course, the morbidity of doing an axillary dissection, we know it's pretty high. Like, you may land up with lymphedema, at least in some proportion of these patients, and you don't want to give the arm morbidity. But a well-performed selective neck dissection should not give any morbidity, and that's what I believe. I think considering the fact that head neck cancers are so common, people are tending to do, and while doing a proper selective neck dissection, you must preserve all the nerve roots, the cervical nerve roots, and especially the spinal axillary nerve, and avoid diathermy injury to some of this. So a well-performed neck dissection, and even in the randomized control trials, it showed that there was initial benefit in terms of the shoulder and neck morbidity, but after 6 months to 1 year, it leveled off. So the fact that you have level 1 evidence to suggest that elective neck dissection improves overall survival and also recurrence-free survival for some of these patients, I feel that a well-performed selective neck dissection is something that can be practiced in the real world, because even in low settings or limited resource settings which are there, you can easily do this and you are sort of, benefiting these patients. But as I said, like, in some tertiary settings wherein you can sort of use, and there is some more evidence of sentinel node biopsies coming up. And I think maybe practices may change, but in real world right now, I think it's very, very difficult to sort of, change practices to entirely shift to sentinel node biopsies. But I agree, this is a very exciting concept. The thing is, early oral cavity, extent of tumor, well-defined and clinical examination. Yeah. I think that was a comment. Does it require CT scan? Yeah. Again, as I said, like, we were a part of the ICMR guideline, which came up in 2014. Some of you can refer to that guideline. What we said was, in some of these cases, at least in T1 cancers, you may sort of, especially when the lesion is slightly, all borders are felt, you may tend to avoid a cross-sectional imaging for these patients. But when it comes to a T2 cancer, and when the cancers are close to the mandible or one of the sulci, then we prefer a cross-sectional imaging. So for a T1 cancer, sometimes you may want, it's sort of, it may not be mandatory, But in T2 cancers, I think it's highly recommended that you do a CT scan to better delineate all the structures, especially the thickness, proximity to the mandible, and of course the cervical bones. What are the definitive indications for NACT? What are the borderline operable? I think this is a hugely controversial topic. I gave you 4 indications, I think the Tata's group, and I also believe that, in some of these indications, especially if there's extensive soft tissue involvement, if the edema reaches up to the zygoma, up to the hyoid, I think the more important and the pertinent issue is the ability to achieve an R0 resection. Somehow, if you're able to achieve an R0 resection, I think, as I said, that surgery provides the best modality of care for some of these patients. So you must go in for surgery for some of these patients. But if you are able, so it's not just the act of surgery. Again, it's very important to give a functional and cosmetic and aesthetic outcome for some of these patients. So if you are able to do that, then by all means, you may go in for surgery. But as I said, the NACT approach seems to be attractive. Close to 40% of the patients seems to be operable. But as I keep saying, that unless and until you involve surgery as a part of a multimodality management, you are not able to give a survival advantage for some of these patients. These patients are slightly advanced cancers, so they are bad prognosis. So it may be a way of bioselecting some of these patients, but as I keep reiterating, surgery has to be in the armamentarium if you want to achieve a meaningful cure for some of these patients. Questions? Trying to, okay. The ideal extent of resection. I'm just trying to go. A lot of questions, so I think. Single node positivity radiation is indicated. I think these are all very, very trick questions. Again, as I said, we believe in the concept of synoptic reporting. So we urge pathologists and also surgeons to engage with the pathologist so that every aspect is important. As I said, when it comes to a single lymph node, traditionally what happens is, I showed in the slide that stages 1 and 2, you may sort of, do a single modality of treatment. When it comes to a single node positivity, at times, it is upstage to stage 3. So radiation therapy is an option for some of these patients. And we would sort of, recommend it for at least tongue cancers. I know buccal mucosal cancers tend to be a little more biologically favorable, but generally for a node positivity, again, it's the institutional practice. Majority of the institutions would sort of, go for adjuvant radiation therapy. But the more larger debate comes with the soft factors. But in node positivity, I think the decisions are much more straightforward. The extent of resection after NACT, I think this is again a very, very tricky question, essentially. Of course, this has not been that well studied. But again, as I said, you tend to sort of, you tend to map the initial tumor extent, and you also map the subsequent tumor extent. You may go you may go wide, but not as wide as you would normally go in a traditional thing. So there is no sort of, definitive answer for this. It's also based on a good clinical examination on table and also do a good radiological examination. And combined with that, you must take up all of that. So to deal with the posterior lesion with the cheek flap approach, even if the patient is having a node trismus. As I said, we tend to avoid a cheek flap if the lesion is accessible through per oral approach. I think that's the larger mandate. Again, that's the reason why the transoral robotic surgery has come in oropharynx cancers as well. Because what happens is that when the lesions are posteriorly located, access is difficult. We know that some of the surgical management in oropharynx is also giving slightly better outcomes for the patients. But because of the access issues, I think the world shifted towards non-surgical management of these patients. But with the advent of robotics, and especially in HPV positive cohort, and more so in the HPV negative cohort, we find that in some of the early cancers, the robotic approach is better. The similar logic is there for the posterior located lesions of the buccal mucosa as well. So if you're able to access it well, and if you're able to give a three-dimensional margin, I think you must go for the per-oral approach as well, and we would tend to prefer that. Very rarely you can do a marginal mandibulectomy also by the per-oral approach, but I would sort of suggest that you must be very, very careful while doing this. I think which, if you're at any point cutting through the tumor or fragmenting the tumor, then I would recommend not to do this approach. But I think in some skilled hands, I think a per-oral approach should be a reasonable way to go about. I did mention about the midline or angle split. We used to, so when I was training, we used to do midline approach and not the angle split approach. But as I said, if you are able to reconstruct the orbicularis oris perfectly well, the angle split approach also seems to be a reasonable approach for some of these patients. Patients with dental amalgam imaging, CT, MRI, I think that's a problem. Some CT gives artifacts for some of these, and you must factor it out. And maybe an MRI would be a complementary tool in some of these patients as well. But even in the presence of dental amalgam, I think there are some softwares of subtraction software. So I think engage with your radiologist well. I think they may be able to do. So I would sort of suggest a complementary both CT and MRI in case of doubt in some of these patients. Early oral cavity with N0 ultrasound neck should be done. As I said, and ultrasound neck is very good for N plus tumors. Of course, in traditional practice, we tend to do ultrasound neck for the N0 tumors as well. But as I said, even in N0, you get a micrometastatic rate of around 30% for the T1 and T2 cancers, essentially. So ultrasound is not that useful for the N0 neck in predicting the incidence of an occult positive neck. But nonetheless, we tend to use it in our regular practice. And also the fact, I think you made a right point, because now that, we do neck dissections, selective neck dissections for all patients, all subsite of patients. Initially, after the publication of Dr. De Cruz, we felt that thin lesions less than 3 millimeters, you can avoid doing elective neck dissection. But after the SEND paper and also the 7 meta-analysis, we now know that, across all subsites, even for less than 3 millimeters, I think there seems to be a benefit of doing elective neck dissection for some of these patients. Question. Downstaging of treatment in HPV positive cancers. As I said, HPV positive are more related to oropharyngeal subsite. We believe, at least in our data of exome sequencing, but that HPV doesn't play a significant role in oral cavity cancer. So I think it's the relevance of HPV is more so in the oropharyngeal cohort, wherein the P16 association is there and they are prognostically better. We've done a couple of publications on this. A group have extensively done some work on HPV in oral cancers right from 2013, 2017. And also very recently, we have got some work on exome sequencing. So I would urge you to read those publications on that. All selective neck dissection should be sent for frozen section. No, this is something that we don't regularly do it. Frozen sections. I think frozen sections can be used selectively in case of the primary tumor, but in case you have any suspicious nodes, then you may want to, you may select. But again, most of the N0, what happens is your extent of surgery is actually guided by the positivity at the level 2A. So there has been very, very rare occurrence in which your 2B or 4 has been positive in the absence of a positive node in the level 2A. So I think I would urge you all to actually look into the level 2A more closely and then subsequently plan your neck dissection based on that. Neck dissection in the clinically positive node. Yeah, I think the concept is changing. Initially, I think when we were training, we were actually doing a comprehensive neck dissection for all the clinically positive necks. There is now data to suggest that you can use a slightly lesser, you can do a selective neck dissection in cases of single node or small positive nodes. And I think there are some contraindications. For example, if there is a node with an extra nodal extension, if it's a large node, then even though it's clinically positive, you don't do. If it's a small neck node at the levels of, say, especially 1B or 2, then you may want to avoid some level 5 dissection in some of these patients, because even in those conditions, the positivity of level 5 continues to be around only 2 to 5%. How to differentiate lip cancer from buccal mucosal cancers? I think that's a very important aspect. I think lip comes, it's a two cancers. So it can be a part of skin cancers, it can be a part of buccal mucosal cancers. The verbalian border of the lip is the distincting part. If any tumor is there outside the verbalian border of the lip, then it is classified as a skin cancer. And a majority of the Western cancers of lip cancers are actually skin cancers which involve the verbalian border. Most of our cancers are involving the labial aspect, that is behind the verbalian border. So it's very important for us to understand that distinction. So lip is actually two cancers. It can be classified as a skin cancer or as a labial cancer or an oral cancer based on the site of involvement of this particular cancer. I think it's 8:30, so I think, should I stop?
Yeah, thank you. That shows, it will never end, man. Thank you very much. I mean, superb. And this is the most common case in the exam, and most of the time they fail because neoadjuvant chemo, marginal mandible to remove node, how to integrate nodes, neck nodes. Superb. Right. Thank you very much, Arvind. It shows that we need to have one more class from you.
Always a pleasure. Thank you so much. Thank you, Navdeep Singh Ji and the NB for the opportunity.
Thank you very much. Over to you, Navneet Singh Ji. Thank you.
Thank you very much, Professor Dr. Arvind Krishnamurthy, for the presentation, and thank you very much, Professor Dr. Somashekar, for joining, and thank you, trainees and faculty members, for joining.
Thank you. Bye-bye.